Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's September 2019 issue. There are 4 articles that have been selected as our Editor's Choice or Highlight articles this month. Our Editor's Choice is an original article entitled Gender Differences in Pain Risk in the Old Age, Magnitude and Contributors. It is authored by Dr. Esther Garcia Esquinas from the School of Medicine at the Universidad Autónoma de Madrid IDIPAS in Madrid, Spain, and colleagues from Public Health and other hospitals in Spain. Pain in life is inescapable and ubiquitous, and its severity ranges from transient, self-remitting episodes to chronic pain syndromes refractory to virtually all therapeutic interventions. A perhaps underappreciated issue is that sensitivity and sensation of pain are sex-dependent, generally being heightened in female as compared with male subjects, a propensity recognized no more than some 20 years ago. Preclinical studies of this phenomenon demonstrate that the biologic basis for nociception differs between males and females, in that microglial cells are critical modulators in relevant neural networks in males, whereas T cells are involved in females, with further modulation provided by sex hormones. Additional discoveries in this field are that the perception and intensity of pain are influenced not only by sex, but also by characteristics of gender, as distinct from biologic sex, of the person experiencing pain, and by the nature of the surrounding milieu, including the sex of nearby individuals. Such considerations have significant implications for the treatment of pain syndromes and the development of novel therapies for pain. In this issue of Mayo Clinic Proceedings, Garcia Esquinas et al. Significantly advanced this field by prospectively evaluating pain and sex differences in community-dwelling older individuals, demonstrating that the relative risk ratio for pain was significantly higher, some twofold, in women as compared to men aged 63 years and older. This increased risk of pain in females was associated with more frequent musculoskeletal disease, greater impairment in functional activity and mobility, and higher rates of depression, psychological stress, and disturbances of sleep. As pointed out by Garcia Esquinas et al., the association between pain and these conditions may be bidirectional, with chronic pain promoting the occurrence and/or exacerbation, and these conditions in turn preventing the remittance of pain. The importance of the paper by Garcia Esquinas et al. Resides in several considerations. First, it highlights that there are sex differences in the risk of pain in older subjects. Second, it uncovers several factors that may drive the persistence of pain. Third, these findings suggest that strategies designed to promote functionality and activity and/or to ameliorate chronic conditions associated with pain may significantly decrease this increased risk of pain. The importance of sex differences in medicine is clearly recognized beyond pain perception to diverse fields, including, for example, the fact that female as compared with male subjects have an increased risk for autoimmune diseases, including systemic lupus erythematosus, but generally exhibit a reduced sensitivity to acute kidney injury and a slower rate of progression of chronic kidney disease. Mayo Clinic Proceedings emphasizes the importance of sex differences in medicine by dedicating one of its sections under the editorial leadership of Dr. Vesna Garovic entirely to this field. The first highlight is an original article entitled High Intensity Interval Training in Cardiac Rehabilitation, Impact on Fat Mass in Myocardial Infarction Patients. It is authored by Dr. Yao Shan from Zhangguoya Hospital, Central South University, Changsha, Hunan, China, and colleagues from Mayo Clinic in Rochester, Minnesota, United States. Cardiac rehabilitation programs for patients recovering from myocardial infarction seek to recruit reparative cardiovascular processes, to improve cardiorespiratory fitness, to reduce mortality, and to enhance the quality of life for these patients. Such programs integrate, among other approaches, the following components: exercise training, strategies targeting secondary prevention for cardiovascular risk factors, education pertaining to pharmacologic therapy, diet, and dealing with stress, and counseling that underscores the need for compliance with such goals and that their core principles should be followed long into the future. A key component is exercise training, as this is of proven value in patients with cardiovascular disease as it is in healthy subjects. Among the various types of exercise training, high-intensity interval training has received considerable recent attention, and indeed is considered by some to provide greater health benefits in the general population when compared with aerobic exercise. This raises the question of the relative benefits of either form of exercise in cardiac rehabilitation programs in cardiovascular diseases. This specific issue is addressed in the present issue of Mayo Clinic Proceedings by Dunn et al., who retrospectively compared outcomes in patients in cardiac rehabilitation undergoing either high-intensity interval training or moderate-intensity continuous training following myocardial infarction. The findings demonstrate that the high-intensity group, as compared with the moderate-intensity group, evince greater reduction in fat mass and abdominal fat, in serum cholesterol, LDL, and triglycerides, and after adjusting for exercise indices and energy expended, the high-intensity group still achieved greater reduction in fat mass, body fat percentage, and abdominal fat. The greater reduction of abdominal fat is of particular pathogenetic and clinical interest. Setting aside the contested obesity paradox, which holds that for certain types of cardiovascular diseases, obesity in a certain range is cardioprotective, the evidence is quite clear that fat mass in general and abdominal fat in particular are risk factors for cardiovascular disease. Abdominal or visceral fat produces a range of cytokines and humoral factors inimical to the cardiovascular system because these factors cause endothelial dysfunction, inflammation, oxidative stress, a procoagulant milieu, and insulin resistance. The occurrence of such vasculopathic processes in the coronary circulation may be especially damaging in patients who previously experienced myocardial infarction. Thus, the finding by Dunn et al. That incorporation of high-intensity rather than moderate-intensity exercise into cardiac rehabilitation programs was attended by greater reduction in abdominal fat invites the speculation that the risk for future cardiovascular disease, including acute coronary events, may be less with such programs. Recent studies have indicated that, using cardiorespiratory fitness as an outcome, high-intensity exercise generally exerts either superior or comparable effects as compared with moderate-intensity exercise in cardiac rehabilitation, and that high intensity is generally considered safe in post-myocardial infarction patients. The present studies by Dunn et al. Are the first to demonstrate that high-intensity interval training as compared with moderate intensity continuous training, is attended by a greater reduction in fat mass and abdominal fat, effects that may be of particular cardiovascular benefit, especially in patients undergoing cardiac rehabilitation. The second highlight is an original article entitled Severe Hypoglycemia Attributable to Intensive Glucose-Lowering Therapy Among U.S. Adults with Diabetes, Population-Based Modeling Study 2011 to 2014. It is authored by Ms. Grace Mahoney from Harvard Medical School and the Harvard T.H. Chan School of Public Health in Boston, Massachusetts, and Optum Labs in Cambridge, Massachusetts, and colleagues from Mayo Clinic in Rochester, Minnesota. In health, hypoglycemia is relatively uncommon because effective homeostatic mechanisms safeguard plasma levels of glucose, the latter representing the brain's vital metabolic fuel. These mechanisms include, among others, the suppression of insulin secretion, increased secretion of glucagon and epinephrine with attendant increase in hepatic glucose production, and increased sympathetic autonomic output that drives food-seeking behavior. These responses are impaired in diabetes, and thus diabetics undergoing treatment with insulin or oral agents are at an increased risk for hypoglycemia, as well as the acute and chronic complications of hyperglycemia. In addition to its acute and potentially lethal effects, hypoglycemia, in particular when recurrent, may cause cognitive decline and dementia. Glycemic control thus requires a fine balance. On the one hand, such control exerts abundant beneficial effects, including the reduction in macrovascular and microvascular complications in type 1 diabetes and in microvascular complications in type 2 diabetes. On the other hand, if glycemic control is too strict, hypoglycemia may ensue. Practice guidelines generally recommend a level of glycated hemoglobin, HbA1c, hemoglobin A1c, of equal to or less than 7% for most adults. This threshold, however, is increased in circumstances when the benefits of such control are uncertain and or the risk for hypoglycemia are increased. Such circumstances include older age, the presence of clinical complexity, and reduced life expectancy. In the current issue of Mayo Clinic Proceedings, Mahoney et al. Examined the prevalence and significance of intensive glucose-lowering therapy in diabetics in the United States. Intensive glucose-lowering therapy was determined as a hemoglobin A1c of 5.6% or less as achieved by one agent, or a hemoglobin A1c ranging from 5.7 to 6.4% as achieved by two or more agents. Clinical complexity was defined by age 75 years or older, end-stage kidney disease, impairment in two or more daily living activities, and the presence of three or more chronic disorders. Using the N. Haynes 2011 to 2014 database, these authors demonstrate that approximately 49% of diabetics in the U.S. had a hemoglobin A1c less than 7%, with approximately 32% of these patients being clinically complex. Approximately 22% of either clinically complex or non-clinically complex patients were intensively treated. Drawing upon prior data by McCoy et al. Regarding event risk, Mahoney et al. Calculated that intensive treatment led to approximately 5,000 hospitalizations and approximately 5,000 visits to the emergency department over a 2-year period. This important study by Mahoney et al. Emphasizes two essential considerations. First, it highlights the potentially life-threatening risks of hypoglycemia induced by intensive treatment, especially so in the clinically complex diabetic. And second, it underscores the need for individualized, evidence-driven, nuanced care for diabetic patients, and in particular, the need to target a higher hemoglobin A1c level in the older, clinically complex patient. The third highlight is an Understanding Disease article entitled Neurologic Autoimmunity in the Era of Checkpoint Inhibitor Cancer Chemotherapy by Drs. Anastasia Zaccharidou and Vanda Lennon from Mayo Clinic in Rochester, Minnesota. Autoimmunity can be triggered by diverse causes, including therapeutic agents such as immune checkpoint inhibitors, ICIs. ICIs, agents that promote T-cell activation, represent a pivotal advance in the treatment and management of malignancies. T-cells are kept in relative inactivity when T-cell checkpoint molecules such as PD-1 and CTLA-4, both represent off switches for T-cells, bind respectively to PD-L1 and B7-1 and B7-2 on other cells. As cancer cells may copiously express PD-L1, cancers can keep T-cells quiescent and thereby elude immune surveillance and removal. ICIs are antibodies that inhibit either PD-1, PD-L1, or CTLA-4, thereby enabling T-cell activation and the role of activated T-cells in the killing of cancer cells. Not unexpectedly, these agents may cause immune-related adverse events. These and other toxicities of ICIs were comprehensively reviewed in the July issue of Mayo Clinic Proceedings by Marin Acevedo and colleagues. In the current issue, Zaccharidou and Lennon expertly used the backdrop of ICIs in current cancer therapy and the attendant risk of inducing autoimmunity to provide an in-depth and comprehensive review of the pathobiology of autoimmunity in the nervous system as paraneoplastic manifestation of assorted cancers. Their review covers the following areas: the concept and types of onconeural proteins and how immune responses to these proteins can target collaterally shared autoantigens in the nervous system, the key underlying immunologic participants and mechanisms involved in paraneoplastic autoimmunity, the different pathways whereby neurologic autoimmune processes target intracellular or plasma membrane residing antigens, the range of IgG paraneoplastic neural antibodies associated with cancers and the accompanying neurologic syndromes, and the clinical serologic correlations for assorted cancers and hematologic malignancies. The authors then return to mechanisms underlying ICI-induced autoimmunity in the nervous system and clinical manifestations of this complication, including exacerbations of demyelinating disease, peripheral nerve disorders, myasthenia gravis, and hypophysitis. The review concludes by calling for vigilance for autoimmune complications in the nervous system in the setting of immune checkpoint inhibitors, especially in light of the increasing use in oncology. This contribution is the first in a new type of article entitled Understanding Disease, a review that provides a clear discussion of relevant pathobiology intended for the generalist and written by the specialist. Mayo Clinic is deeply appreciative of this inaugural contribution by Zaccharidou and Lennon and invites other experts to consider submitting articles in their respective areas of expertise to Mayo Clinic Proceedings for consideration in the Understanding Disease category of article. You can access these highlights and editor's choice articles free of charge during the entire month of September. When you visit our updated Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you will find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page, as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who've made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.